So thank you very much, Professor Abubakar. That was absolutely fascinating. Can I now present Professor Pierre Buekens, who is a W.H. Watkins Professor of Epidemiology at the School of Public Health and Tropical Medicine, and now you're Professor of Obstetrics and Gynecology at the School of Medicine at Tulane University in New Orleans. He was Dean of Tulane School of Public Health and Tropical Medicine from up until 2018. He is also, you'll be glad to know, here is a corresponding member of the Royal Academy of Medicine of Belgium and is past chair of the board of the Consortium of Universities for Global Health. Professor Buekens.
Thank you very much for the kind introduction. Thank you to the academies for inviting me. Special thanks to Professor Fodard. And let's talk about women and babies. And let's start where I live now in the US, and perhaps close to my heart because my wife is Mexican. For a long time now, about 4 decades, it has been recognized that there is an epidemiologic paradox. If you look at infant mortality, it is actually very similar if you compare non-Hispanic whites versus the children of women of Mexican origin. And why is this a paradox? Well, because women of Mexican origin are more often of low socioeconomic status than other non-Hispanic, than other women. And so, you know, the perinatal epidemiology religion tells you that infant mortality is closely related to socioeconomic status, and this was an exception. There is within that paradox a Mexican paradox, because among women of Mexican origin, if you look at infant mortality of their children, it is lower if the mother of the baby was born in Mexico and was thus a migrant to the US. So that's a supplemental paradox which exists for mortality but also for birth weight, where you again see this unexpected low rate of low birth weight. And there again, you know, the perinatal epidemiology theory tells you that if you are of lower socioeconomic status, you will have smaller babies. And clearly there is an exception there, which it's again true if you look among women of Mexican origin, you see that the probability to have a small baby is actually lower if you are migrating to the US than if you were born there. And this is actually another example of what was just discussed right now, of the fact that often migrants have very good health outcomes. This was discussed this morning too. And you will tell me, well, this must be a healthy migrant effect, which is something which we always have to keep in mind. You know, if you migrate, you're probably in good health, because if not, you cannot, you know, take on the journey. But when you look at data, which are not easy to find, because you need comparable data from both countries, the country you're coming from and the country you're moving to, it's not that obvious that there is a strong healthy migrant effect. For a long time, you know, this is coming from the beginning of this discussion in the US about the Mexican paradox. People were looking at these data. This is the distribution of birth weight. You know, it's a normal distribution with a tail. And as you can see here, you see that the Mexican Americans have actually higher birth weight than the babies born in Mexico City. So that was a kind of an argument to say, well, there is a selection in the ones migrating, but that was just forgetting something. Mexico City is at 2,400 meters of altitude, and altitude is a very strong determinant of birth weight. If there is something constant in perinatal epidemiology, is the relationship between altitude and birth weight. It's always observed, and when you adjust for altitude, no difference anymore. So it was probably, in this case, not a healthy migrant effect, but keep healthy migrant effect in mind, because it can affect the results, of course. Now, that was the US. That's about the time I spent a sabbatical at UNC Chapel Hill, and I became interested in trying to compare the situation in the US and in Europe, in Belgium and France, and with Sylvia Gundelman at Berkeley, we did a secondary analysis of available birth certificates data, making the comparison as similar as possible. It cannot be exactly similar because the way you define ethnicity and it's different. In the US, it's acceptable to ask about ethnicity, but we were able to really get as close as possible by, in the US, comparing US-born versus Mexico-born babies. This is about low birth weight, less than 2.5 kilograms. And in Belgium, comparing the babies of women who had the Belgian nationality at birth versus the ones who had a North African nationality at birth. So it was kind of close enough, and all the rest of the analysis, the adjustments were done the same way. And I guess we got lucky because we found exactly the same odds ratio, as you can see. So in the US, the Mexico-born woman, had about 30% fewer low birth weight, and we found exactly the same thing in Belgium and actually in France too. So there is a migrant paradox in the US, and for birth weight there is also a migrant paradox in Europe. But there was kind of less attention paid to this for a while. And there could be some kind of reason for that, maybe the way you see migrants as being positive or not. I mean, in the mind of the researcher, I don't know. So, what is happening there? I mean, how can migrants have fewer low birth weight than non-migrant? And if it's not mostly a healthy migrant effect, what is it? And this was also mentioned several times this morning. It could be a protective culture. Many migrant women do not smoke, and that's a major determinant of birth weight. Absolutely major. Many do not drink alcohol. They have a more traditional nutrition, and they often have very strong social networks, and that decreases stress, and that has been documented as being a risk factor for low birth weight. And when you lose that by acculturation, as it is the case with mental health, we saw this morning, you might lose that advantage. So we have to always keep that in mind. We have not only to make sure that migrants are welcome, but also that they are in the conditions that they can keep everything which is positive about the culture of the country of origin. Now, how can we really try to measure the impact of acculturation? In the US, there are many acculturation scales, mostly based on language and culture and what you watch on TV and things like that. There are a few in Europe, but not many. But there is a proxy, perhaps, which was mentioned also this morning by one of the speakers, is what's happening when you get the nationality of the country, when you naturalize, when you get the nationality of the country you're moving to. Now that's just one way to measure a definite change in your status. And when you look at the impact of naturalization, and we did this in Brussels first, and then Julie Rakapet did this for the entire country here in Belgium relatively recently, Well, first, you see the paradox, right? The odds ratios for migrants are clearly lower than 1, showing that they have fewer low birth weight babies than people born in Belgium and with Belgian nationality. But you also see a slight deterioration of that advantage when they naturalize. Well, it's statistically significant because it's a huge sample, it's the entire country, but even though it's a small country, you know, but still it's a big sample. But it's not very, very convincing. So if you look at the studies on acculturation, it always gives the impression that we don't have enough information to really understand what's happening there. So that's for low birth weight. Now, let's move back from low birth weight to mortality, but this time for Europe and for Brussels. That's a different story than in the US, because you remember my first slide was about the epidemiologic paradox for the US. And women of Mexican origin, their kids had lower infant mortality. But it's not the case in Belgium. In general, it's not the case in Europe. You often see higher perinatal, neonatal infant mortality for certain groups of migrants compared to the non-migrants. So that's a concern. There are different populations. I'm not saying you can compare. I'm just saying that's a concern. So there is a migrant paradox for birth weight, but there is no migrant paradox, unfortunately, for mortality in Europe, or here at least in Belgium. And if you look at the impact of naturalization, it's different than for birth weight, because here you see this slight increase, but we're talking about death. So in terms of numbers, it's quite important. But you look at the odds ratio for North Africa compared to Belgium, you know, it's 12% higher, 1.12. And when you look at the naturalized woman from Maghreb naturalizing Belgium, there is no difference anymore. So it seems that there is indeed an impact of getting the nationality of the host country, a positive impact on mortality, on perinatal and infant mortality. That suggests, without proving it, that a better access to care is making the risk of mortality equal to the one of the native population. Inversely, it suggests that the excess in mortality is probably linked to some problem of access to care. And talking about access to care, and going back to the map which was shown this morning by our colleague, the only thing you can see on this map is what you saw this morning. The one this morning had color, and it was better. I like the green, orange, and red. What you can see is that there is a lot of diversity and different systems in Belgium, in Europe. So hard to compare. But if you go down the street from here, you know, you can take the metro or you can walk, it's close by, and you go to Hospital Saint-Pierre, Saint-Peter, where there is a long tradition of really supporting and helping anybody of low socioeconomic status, and especially migrants. You will find in this very recent study, actually published this year by Patricia Barlow, Serge Rosenberg and their team, encouraging data. Again, it cannot be generalized, but it's encouraging. They compare, the middle column are the women with aide médicale urgente, the special program giving access to medical care, in this case to obstetrics care, even if you are undocumented and even if you don't have any other health insurance. The first column is the Belgian social security system. The last column is the woman with no coverage at all. And if you look at the results, you look at the C-section, for example, the last line, it's pretty similar from, 19%, 16%, 21%, almost no difference. So that's very encouraging. It means that in Hospital Saint-Pierre, the Belgian system of AMU is giving similar access and type of care to everybody. It also suggests that there is no over-medicalization of migrant women, because the risk is not only to have too little care, it's also perhaps to have too much care. And we worked on this with colleagues here at ULB a few years ago, and we looked at C-sections among different groups. And there was no difference between women originally from the Maghreb region, North Africa, and women originally from Belgium. But there was a real excess of C-sections among women from sub-Saharan Africa. And that was published 3 or 4 years ago. And it was really unexplained, because we look at the Robson classification, and the excess was among normal delivery, vertex, no complications. So this is an unexplained variation. I'm sure there is an explanation, but I'm not sure what it is. So we have to think about this, because in France, Catherine Deneux did a similar study and found a similar results of an excess of C-section, specifically among women of sub-Saharan Africa. And I think we really need to try to do more in-depth studies to try to explain this, because I don't think it can be explained by medical factors. It can be explained by communication problem, different attitudes from doctors and maybe women. I don't know, but we have to look at that. So keep in mind that we have been talking today mostly about lack of access, but over-medicalization is also potentially a problem. Now, I would like for my last three slides or 2 slides to shift topic a little bit, and not to talk about refugees or migrants, but to talk about a slightly different situation, but I think we have to keep it in mind in a positive way. We have to keep in mind that war is good for babies. This famous book describing the unexpected drop of infant mortality during the First World War in the UK, and explaining why it happened. More support to pregnant women, better nutrition programs, women being empowered to get jobs and take their lives into their hands, all that, better surgical facilities, all that explained this unexpected result, which was also observed during the Second World War, where you see this drop in the middle of the war, except of course when there was the Dutch famine, during the siege of Amsterdam. That's different, and I'm not saying that war is good, but I'm saying that it is unsettling to observe that in the middle of a war, we have been able, except in the middle of the combat, we have been able to improve the conditions. Of course, it's compared to the Great Depression, right, which was terrible, but remember, in the UK, this is a facsimile of a food stamp, a ration book, You can see this as being negative, it's a ration book, or you can see this as being food stamps, which certainly didn't exist during the Great Depression. So in Belgium, the situation was actually the same. You can see it on this graph, but we published these data from Belgium, which are even more unsettling, because the story in the UK is that, of course, we were so organized that we were the winners, and so, but, in Belgium, situation was different. But in part because of the help of the Maternal and Child Health Organization, ONA, in Belgium, in part because of the food stamps, in part because of other reasons, we also observe this. So if we can do this during the First and Second World War, we should be able to do this also for refugees. So I think the lesson for me is that we should expect achieving better, not equal, but better perinatal outcomes among migrants than among non-migrants. Perhaps because of the healthy migrant effect, perhaps because of difference of culture, perhaps because when we want, we can provide better care. But we should expect better perinatal outcomes. And the contrary, if where you are, you don't find better perinatal outcomes, then I think that would highlight most likely a major failure of the health system. And I think it's this kind of positive approach that I would recommend. And I would like to end by this sculpture, and I could maybe organize a quiz and ask you where it is. You might not immediately say that this is actually on the riverfront in New Orleans. It's a statue to the Italian immigrant. And it just reminds us that we are all coming from somewhere, including most likely everybody in this room, except if you were born in the Rift Valley in Ethiopia. Your ancestors moved from somewhere. And so we have to keep that in mind. Thank you.